Thank you so much for tuning in today. I really appreciate the opportunity to speak with all of you about our experience with IGRT and treatment delivery for extracranial SBRT, particularly in the lung and the spine today. Just full disclosure, I have a tendency to speak quickly. I will try very hard to not rattle off super fast, but I just wanted to throw that out there that it's a tendency and it's something I'm working on. So please
we'll slow you down if it becomes too fast.
Yeah, perfect. Slow me down. Really excited to be here. So I thought it would be helpful to take a step back and look at where we are today within the RCC, SBRT, and SRS curriculum. So far, many of you have talked about why do SBRT, what is the value in SBRT, and also looked at any QA considerations around small field radiation. And then also there were a couple sessions on the simulation for SBRT, particularly on immobilization and registration, both for intracranial and extracranial body sites. When we're talking about extracranial body sites, we really need to look at motion management. And that was definitely an area that was delved into in past sessions. And then I also saw that there were case presentations. So for today, we're going to continue forward and talk about IGRT considerations. And the main focus is going to be specifically on lung and spine. So IGRT stands for image-guided radiation therapy. And oftentimes in conversations about IGRT, we can think about how we've actually really always been doing some form of IGRT. If you've been doing portal imaging for a long time or film, we've been using images. But really with the advent of cone beam CT and the ability to acquire 3D images at the machine, it's really taken IGRT to a whole nother level. And it's really allowed us to target tumors in a way that we weren't able to before with just planar film. So now we can target the tumor using 3D images with the patient in the treatment position. Those images are acquired immediately prior to and even during treatment. And this allows us to aim to manage, to better manage inter and intrafraction variability. I'm going to talk just a little bit about the specifics of that. So interfraction variability refers to the differences between fractions. So in SBRT, oftentimes we're treating patients in less than 5 fractions. And so how are they setting up? What is the difference that we see from fraction 1 to fraction 2 to fraction 3 and so forth? That's called interfraction variability. Intrafraction variability is variability that you see during that particular treatment. And here's a nice chart. I tried to find the original reference for this. It's been used many times in presentations. I think it's from a textbook. So I apologize for not putting an initial reference here, but there's a number of different setups and different types of errors that fall into the category of interfraction variability and intrafraction variability. And they can then be further categorized into whether they are considered setup errors or organ motion related variability, sources of uncertainty. And the reason it's important to just touch on this momentarily is because IGRT really helps us reduce the uncertainty associated with these factors. It helps us reduce setup variation. It helps us reduce internal organ displacement because we can actually see inside the patient. It helps us reduce uncertainty around volume changes. If we notice that the anatomy of the patient has changed, we're able to see that now. And we're able to see volume deformation. How has the shape of the organs, internal organs or tumors change? And because we can reduce this uncertainty, we're able to use tighter margins, deliver higher doses, and essentially allow us to do SBRT. So IGRT is really important for an SBRT program for all of these reasons. Also, SBRT requires precise localization of the target, the tumor and also the normal tissues at planning and also at the time of treatment. You want to make sure that the beautiful isodose plans that you generated on your treatment planning system is something that is also going to be delivered at the machine. And we're also delivering higher fraction doses to smaller targets. So if we don't do IGRT appropriately, then there is a risk that we're going to miss. And that may lead to increased toxicity. It could lead to causing injury, decreased tumor control, and certainly poorer outcomes. So this is sort of the context in which we're going to have a conversation about IGRT and the value it brings for an SBRT program and why this is so important. So I'm going to focus on lung and spine. What I'll do first in this session today is we'll go through and just really focus on lung, and then we'll then pivot to spine. I didn't want to really jump back and forth at each of the different stages of IGRT treatment. We'll review key concepts from simulation that inform how we do IGRT. We'll discuss and review IGRT for lung and spine, and along the way, touch on some examples. And my goal is to really make this practical. So I won't go broad and sort of didactic. I'll try to keep it very specific and practical and hopefully share some lessons that I've certainly learned throughout my experience in the SBRT, IGRT space. And please, if you have any questions, post it in the chat, and I just moved the chat window so I can see it. Okay, so for lung SBRT, we're going to start with lung. Let's back up a little bit and review simulation. I know there was a session devoted to motion management and simulation. I think this is really important to just refresh. So what is our primary source of uncertainty for lung SBRT? There's a whole host of different things that go into uncertainty when we're treating high doses to lung tumors. But I'd like to hear, you can either post it in the chat or share what are your thoughts in terms of where are we primarily worried about when we're treating lung SBRT?
Feel free to type in the chat.
Yep, lung motion. Breathing. Yep, exactly. We're really worried about respiratory motion. Perfect. And here's a really, really nice graphic that I feel is just captures a really good sort of sense of how lung tumors move and just kind of spans the sort of a map of the lungs. And this is a reference from Steppenwoldt, published in the Red Journal back in 2002. And basically this figure is orthogonal projections of the trajectories of 21 tumors. These tumors are displayed at the approximate position based on the localization mentioned in the chart. And any tumors that were attached to bony structures are circled. So they really try to estimate or outline how these tumors move based on where these tumors are located in the lungs. And the circled tumors or structures are the ones where they're attached to something, attached to bony anatomy. And you can see these don't move very much if they're attached to something. And that makes sense when you think about it. But it's the tumors that are not attached, certainly the tumors that are rare in the lung, tend to exhibit more significant motion. And this is really why we want to manage this motion, understand it, characterize it, and account for it in our SBRT treatments. So 4D CT acquisition is a key tool that we use to manage motion, especially in lung. And I'm going to touch on some just key parts of 4D CT because I think it's really important to understand how 4D CTs are generated, because that's going to also inform how you generate your ITV. So what happens with 4D CT acquisition is the respiratory signal, that the way that the patient breathes, we refer to that as the respiratory signal, is acquired at the same time as a slow CT scan. So the patient's lying on the table, they're breathing. You can imagine a sinusoidal respiratory trace that, as you breathe in, you breathe out, you breathe in and you breathe out. And as they're breathing, the CT scan is acquiring data and rotating around the patient. And essentially 4D CT has a CT with 4D CT capability, collects the respiratory signal, knows how it's acquiring the images, and correlates them in a way that is helpful for us, where you see that motion loop that I'll show you. What's really important to keep artifacts, or to try to help reduce artifacts, because you can get a lot of artifacts from motion in these kinds of acquisitions, is to really make sure that we have at least one full breath cycle per helical CT rotation. So one full breath cycle refers to basically peak to peak or trough to trough in a respiratory trace. So the zero phase, by definition, we declare zero phase is full inspiration, and that corresponds with a peak on the respiratory trace. 50% phase refers to full expiration. That is the trough of the phase. And then 10, 20, 30, 40, and all the other phases in between are just divided up evenly or spaced evenly between 0 and 50, or between 50 and the next 0. Okay. And so you want one full breath cycle, meaning peak to peak or trough to trough, at least one full breath cycle per rotation of the CT. And the software will then bin these images by phases, and I'll have a graphic that will hopefully explain that a little bit more. Most 4D CT scanners, the way they're set up for 4D CT acquisition, have this set up already. So the pitch of the scanner is configured such that you generally do not have to worry about this. The only time you really might have to worry is if you have a patient with a really, really slow breathing trace, and you might see some artifact. And so won't go into it here, but certainly there are certain artifacts to look for that if you see it, then you may want to adjust the pitch of your CT scanner. But for the most part, you don't have to worry about it, because the default setting is set up so that you're oversampling for the most part. It's usually 1.5 or 2 breath cycles, and patients generally breathe quick when they're in sim. There's a little bit of anxiety. Sometimes they fall asleep. That's when you might get a really slow waveform. But generally speaking, for simulation, you don't have to worry about this. I just really wanted to call it out because it is important to know. So when we talk about binning, what I have on the left is a phantom. It's from Modus Medical, and it's a motion phantom. And when I talk about binning, what I mean is the scanner will take images associated with the 0% phase, each of the 0% phases. So the image here, the image acquired from here, and so forth, collect them all and create an image data set called 0% phase. So this image data set represents the patient at the 0% phase of their respiratory cycle. And it does this for each of the 10 phases. So you end up with basically 10 images of this patient. And each of these, if the patient has a very regular respiratory cycle, you can get a very, very nice understanding of how the tumor moves through as the patient is breathing. And here's from those 10 phases, you can have software on the scanner or in your treatment planning system that'll combine those in a way that you get this movie loop. And it's just playing through these 10 phases in this way. So you can see how the tumor is moving.
Great. And then the far left, that's the axial, and then sagittal and coronal.
Yes, exactly. Yeah. Okay. This here is just another chart that maybe might be also helpful to understand. Again, it's pulling images from the same spot of the same phase of your respiratory trace and binning them, basically summing them together into one data set. So this data set called mid-exhale is filled with images from this point on the respiratory trace, plus this same exact sort of phase, plus this exact phase. And so these, just in this snapshot here, these 3 images are been together or compiled together to form a data set that correlates with this mid-exhale state. And the software does that for each of the 10 phases along the respiratory. This is a really nice reference paper here, and I've put this at the end of my slides as well. But if you want to read more about it, that's also there. It's a very good paper. Okay, so we've talked about 4D CT. From that 4D CT, because we can capture the motion of the tumor, we're now able to create an ITV. And here's just an example video of a patient's 4D CT. We have this green structure is the ITV, and you can see that we're playing through the movie loop and that this tumor stays within the contoured ITV. Oh, yeah.
Can I have a question?
Mm-hmm.
Yeah, this motion that we see it now on the screen and the target between the green circle, this motion is characterized by certain phase. So this motion particularly, let's say, on the 0 phase or 50% phase?
No.
Or this is the whole circle?
This is the whole circle. Exactly.
Okay.
Exactly. Yeah.
Okay. Okay. Thank you.
Mm-hmm. That's a great question. Yeah. This is the whole thing. So it's hard to see, but if you can see in the upper left, it says frame 1. Play it through. It's going through different frames. The video is a little bit choppy. I apologize for that. But you can see how it's jumping through the different phases. So it's a composite of all of the phase data and looping through it to create this movie, the seemingly movie loop.
So what's the value of having a movie for certain phase, particular, let's say, just clumping the whole 0 phase pictures together and see it together? What's the value of that?
Okay, good question. I'll get to that in just a second. One thing I want to share is also that if you notice, tumors don't just move in lines. They sort of sometimes can move like this. They can move antipose. They can move lateral a little bit. So for places or centers that maybe don't have 4D CT capability, you can do inspiration acquisition, exhalation acquisition, and sort of sum the 2 scans or make a composite scan of that. And that'll get you close. The reason 4D CT is better is those phases in the middle are going to give you the detail of information about this additional antipose and lateral motion that may not be captured in just taking into account your inhale and exhale images. And so if you just take your inhale and exhale images, it's important to use larger margins because of that error, because you're not going to see that information during the respiratory, in the middle of the respiratory cycle.
Yeah, so those points help to adjust the margins on the lateral end.
Right.
Yeah.
Right. Okay. Exactly. So, my ITV here, it's not just a perfect cylinder in any dimension. There's some variation here. So there's some, what's the word? Asymmetry. There's some asymmetry in these tumors. And this is one example, but there are other examples. And the challenge is you don't know until you scan the patient. You don't know how their tumors move until you've got some kind of 4D image acquisition. Okay, so this is that same patient. And what I've done here is each row is a different data set of the same patient, or different a different CT set. So the top, this is the 4D CNA. That's what we were just playing on the previous slide. So this is the movie loop going through all the phases. The middle row is the maximum intensity projection image set. And it's just a static image set. It's not a movie loop. The bottom row is the mean intensity projection, or the average. And I'll talk a little bit about that. So basically, again, let me see if I can go backwards. Okay. Sorry. Okay. So again, the top is the 4D image loop. It's looping through the different phases. The middle is the maximum intensity projection essentially what it's doing to generate a maximum intensity projection is it's taking all those phases and summing them together and basically or overlaying them together. And if whatever in a particular voxel, okay, I'm trying to think of how best to show this. If you imagine you've got 10 pieces of paper, so each piece of paper represents a phase, and you've got a stack of 10 papers, or transparencies actually is a common example. And you were to take a ray, a pencil beam X-ray, through a particular coordinate all the way through. And you look at all of the intensities you would hit. What is the maximum Hounsfield unit value you would get at that particular point? That's your maximum intensity projection. And you do that throughout the entire data set. What you generate here, if you look at the image, is a very nice image of the tumor like throughout its entire motion. So it's completely filled in the ITV here. And then the mean is, instead of just picking the maximum intensity through a particular projection, you're averaging. So there's a phase where the tumor is not at that particular point, and then it enters that point, and then it goes out of that point. And so where the tumor goes in and goes out, you're going to get less intensity, or a less Hounsfield unit. Where the tumor is always there, no matter what phase you're in, you're going to get a more intensity, or a larger Hounsfield unit value. Okay, so this is called the mean intensity projection. This is called the maximum intensity projection. In the software that does 4D CT, so this can happen on your scanner, or if you have a contouring package or in your treatment planning system. When you import your 4D images, the software should have the ability to create this maximum intensity projection and this mean intensity projection. The software will do that for you. And why this is useful is the maximum intensity projection image is helpful for contouring this ITV. If you don't generate this maximum intensity projection, then the other thing to do is actually contour your ITV on all the phases, essentially contour this tumor on all 10 of your phase data sets. But a nice sort of shortcut is to just contour it on this maximum intensity projection. Basically, it looks like just a CT scan with a brighter spot for the tumor, and you would contour that. Then you use the 4D CNA to check the ITV. You play through the loop and you make sure that the tumor is within the ITV that you have contoured. Okay. And then finally, this mean intensity projection is what we use for planning. So I wanted to just kind of put all three here to, number one, sort of compare the images, and also have a framework for how a proposed way to use them in a way that's helpful and in terms of generating SBRT plans. Okay. So again, when I'm playing the movie loop, I'm checking to make sure that the ITV I contoured stays within my green contour, my green outline here. And then after checking that, I can then do a PTV expansion, and then that contour then needs to get transferred to the mean intensity projection image here for planning. And this is what we use for treatment planning. This is also going to be what is loaded on the machine as your reference image. So when we get to the point where we're at the machine and we're loading up the reference image, it will be this mean intensity projection image that's loaded. In this scenario, in this case, the green ITV, the green ROI was the ITV. The red structure here was the PTV, and it was an expansion of 0.7. And what was determined from that is the tumor itself. If you measure, I didn't actually measure. I showed the measurement on here, but it moved about this dimension in the soup imp dimension was about 1.5 centimeters. And so a 0.7 expansion is about half of that. And so it was uniformly expanded in this way for PTV expansion. Yes, the mean IP is the average. Yes. Yeah. Good question.
And then there's a question from Abid. Why can't we use the min or max IP for planning? Why do we use the mean intensity projection for planning?
Okay, that's a good question. Some places I think do use the max IP for planning, but generally we recommend using the mean IP because the tumor is not, the maximum intensity projection is not actually what the tumor is. It's not actually a structure that fully encompasses this green contour. So there's some dosimetric error there. So additionally, I think also for dose calculation purposes, we like to use the kind of more like average IP. It's also a little bit, I would say, more stable because this maximum IP, depending on what kind of artifacts you might get in your 4D CT acquisition, there may be, I guess, bright pixels that are not necessarily related to your tumor. And that's why it's important to double check on the cine loop, because watching the cine loop, your eyes are able to track a tumor moving, and you're able to see, okay, that those voxels are part of my tumor versus other voxels are not. So generally speaking, that's why we use the average IP. Do you fuse the CT with PET? Yes. Sometimes we do. We do get PET and we fuse them. And that can be helpful in terms of also just confirming, actually more like confirming our PTV and also just our ITV. But ITV generation is only based on our 4D CT. So the PET image informs, you have our ITV, and then oftentimes you'll have maybe your GTV contoured from the PET or a CTV contoured from your PET. And then those two contours together will oftentimes help inform the clinician on what kind of margin to put or how to do their PTV generation.
Good. And we have a good question from Mary Aziz about fusing CT with PET. And first question is, do you fuse the CT with PET? And then second question, and if so, which SUV are you considering to be GTV? And I can help answer this as well.
Yeah, so that's a good question. So my experience has mainly been on PET CT acquisition acquired together. So in terms of sort of fusing a PET scan separate from a CT scan, I've done that in the past, and it's been sort of more of a general eyeball, gross eyeball, because the PET doesn't have any anatomical data. In terms of the SUV value, yeah, Ben, do you have a?
Yeah, so from a radiation oncologist standpoint, I use the PET CT to help show me where is the tumor. And sometimes you have instances where there could be some grayness and you don't know if it's active disease or not. But once you know where the tumor is, you really need to try to discern with your eyes, looking at the CT scan, how big is the tumor? Because let's say the PET CT scan was taken 4 weeks ago, the tumor could have grown. So you can't just rely on the brightness you see with the PET CT. You always need to consider what it looks like the day that you do your CT simulation. Similarly, sometimes the PET CT gives you some information, but really the MRI can give you extra information you need to most accurately draw the tumor. So you need to use all the information that you have and not just the PET CT. We have another question from, can you help explain the meaning again of maximum intensity and mean intensity projection?
Yeah.
You had your 0% phase?
Yeah.
Okay. It's okay, I've been doing this for a while. This is the 25% phase?
Yes.
And then when we get to the peak,
yeah, that's a 50%.
This is the 50% phase.
Exactly. Okay.
And then I guess the max intensity projection, if you want to draw on mine, you can go to the toolbar and click annotate.
Go to the toolbar.
It's at the top.
Oh, I see. Okay.
Mm-hmm.
Okay, so I'm going to try not to screw up your drawing. Okay, so the maximum intensity projection would look something like this, where the whole thing is filled.
Okay.
Yeah. And everything is basically, everything in here is filled with tumor or because we have the tumor here, that's what's summing up here. We have the tumor here, and that's going to fill in, that fills in the middle. We have the tumor here, and that fills in here. So it's the Boolean sum of all of these structures together. So that whole thing is filled with tumor.
Mm-hmm.
Okay, that's the maximum intensity. The average intensity?
And the minimum?
Okay, the minimum intensity is basically kind of only where all three intersect. That's the minimum intensity.
Mm-hmm.
So you end up, the minimum intensity would be something kind of like this.
Actually, in this case, they don't.
Well, yeah, okay. So usually it's like I guess in this particular example, it would be something like this and something like this. But generally speaking, we don't have quite the same. And that's your min.
I would say for practical purposes, like just don't think about the min. We never use the minimum intensity projection for anything.
Yeah.
And then the mean intensity projection considers how long is the tumor in each position. Because the max isn't considering the time, but the mean is considering the time. So we know we spend more time with expiration than we do with inspiration. You can see when you breathe. So the mean is going to be weighted more towards expiration when the tumor is higher.
Actually, Ben, I have an example I could show on NIM, maybe.
Oh, sure. Yeah, click the X to exit out of the annotate.
Oh, got it.
Okay. And then you can share your screen.
Okay, share my NIM here. Okay. So I have the same phantom. It's a little bit easier because it's just a cylinder of a sphere. So geometrically, it's a little bit easier to maybe understand. So at the top here in this top row is my 4D movie loop. All right. So it's going through the different phases. If you can see as it cycles through. So let me pause this, and I'm going to go phase by phase. So 50, 60, 70, 80, 90, 0, then back to 10, 20, 30, 40, 50, 60, 70, 80, 90. Okay, so I'm scrolling through the different phases so that you can see how those 10 phases come together to create this 4D CT movie loop. Okay, and that pink outline there is what we call the ITV because it encompasses everywhere that the tumor is throughout all of these phases. Okay. So the second row is that maximum intensity projection. You can see the entire ITV is filled. It's as if the tumor exists in 100% the whole time at all of these locations. That's the maximum intensity because it is taking, I see a tumor here. So I'm going to fill that in up here. I see tumor here. I'm going to fill that in here. I see tumor here, 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 here. And all I'm doing is taking the largest Hounsfield unit through in each of these voxels here. And that's why it's all filled in. So basically maximum intensity is your ITV completely filled in as if the whole thing was a static tumor shaped like this. And then this is the average or mean IP. And as Ben explained really nicely, it takes into account how much time the tumor is in the space. And sorry, I'm talking about the third row where my pointer is black. It also can appear like the correlated pointer on the top two rows is blue. So I'm talking about down here. Yeah. So this down here, it's showing time-based where the tumor is located. Okay. Yeah.
And then you can see how since the ball is spending more time in the middle as it goes up and down, you can see that the middle is more attenuated. It's wider. Whereas it's only spending a little bit of time at the very top, so it almost looks black at the top, and a little bit of time at the bottom, so it almost looks black at the bottom. And that's why you can't just use the mean, because you might be missing the edges where the tumor is only there for a split second. You don't want to use the max for planning, because that's giving you a false representation of how the tumor is with regard to time. So you need to use 4D, CD, cinema, or cine to fully see where is the tumor during all phases of motion to draw the ITV. Okay, is contouring, so maximum IP is a combination of multiple CTs in different phases. Yes, that's correct. Is contouring on the mean intensity, is contouring on the max intensity projection can affect the accuracy when calculating on the average. Contouring on the maximum intensity projection, the problem with that is that it might not be accurate. Imagine that there was a blood vessel. The blood vessel would look exactly the same as tumor because it's bright. So you might be contouring too much if you use a maximum intensity projection. Also, imagine if the tumor was very close to the liver also looks bright. And so the two will get confused. The max intensity projection doesn't tell you what is bright, it just tells you something was bright. So you need to look at the movie to see, follow the tumor, follow it with your eyes, and use that as your source of truth. And then you want to make sure at the end of the day, all of your contours are on one CT set.
Yes.
So we use the mean or the average intensity projection for all of our final contours, where where we put them. It's going to be one DICOM file. We'll have all our OARs based on the mean, and then we'll have the GTV based on the mean. The ITV we'll have drawn using the 4DCT cinema, but the ITV is going to be located on the mean structure set, and so is the PTV. Hopefully that helps.
Okay.
Okay, let's continue.
Yeah, let me switch back. Okay, I think it's definitely important to make sure we understand 4DCT and ITV in the context of SBRT and IGRT. So it's definitely well worth like digging into, and it can take some time to have it kind of stand. Sometimes you have to kind of play with it and look at it more and more. So shifting from simulation to IGRT, because we're not going to talk about planning today. So we're just going to kind of assume plan's done, looks good, contoured on the average IP or the mean IP. And what I just want to mention here is that there are numerous IGRT technologies available. Not all of them are appropriate for SBRT. And I don't want to confuse, and certainly at the right time we can go into each of these different types of IGRT technologies. But what I just want to point out, what I'm going to focus on in this array is really cone beam CT, primarily cone beam CT. And there's a couple of moments where I'll talk about orthogonal pair portal imaging in the context of spine SBRT. So we're going to really focus in on cone beam CT because that's generally the most commonly used technology for SBRT, particularly lung and spine. And it's also appropriate to use for those types of cases. So kind of setting the stage, I thought it would be helpful to first sort of think about what does a typical IGRT process look like for non-SBRT? So just to kind of compare and contrast, what are the additional considerations we have to take into account when we are doing SBRT versus non-SBRT treatments? So we have the patient enter the vault, and then what do we do? What are some of the things that we do next?
Feel free to type.
Feel free to type.
What are some of the typical IGRT process we use when the patient enters a vault? Okay, maybe.
Yeah, we can go on. So, we basically, patient enters the vault, and oftentimes the first thing we do is we will set them up on the table. We set them up on the table using any of the immobilization devices from SIM. We'll then acquire images Once we've got them set up, we make sure that they are in the right position. So we'll acquire some images that may be cone beam CT, it may be orthogonal port films. We register those images with the planning or reference images. That can be your simulation CT or your DRR. If you use support film, you apply your shifts and then you deliver treatment. So this is sort of just high level what we typically do for a non-SBRT IGRT type treatment. For SBRT lung, that first, just I want to go into each of those steps and kind of highlight and make some points about things to consider that look out for when you're going from non-SBRT to in this process. So when you're setting up the patient on the table using your immobilization devices from your sim, this is important anyway, but it is particularly important, especially for SBRT, detailed notes about positioning of the patient, even things like your arm and your feet position. And I know this was mentioned in past sessions. Photos are super helpful. Arm and feet position, while it's not really what we're treating, can really affect the way that the body is positioned, whether they're twisting, whether there's some rotation that you can't see, whether they're not really aligned along the sup-imp axis. So here's just an example. This patient was not able to have her arm up and, the table's narrow and she needed extra support for her hand to be comfortable. And so, detailed notes about left arm resting on a foot block, and add a picture to also show exactly what that setup looks like. Keep in mind that SBRT treatments tend to take a longer time. They're only in for treatment for a few fractions, 5 fractions as opposed to 25 or 30 or more. But those sessions can take a long time depending on the case. So it's really important that the patient is comfortable. They're not wiggling, they're not shifting, they're not coughing. And so details like this can be really helpful. So I wanted to show that, your therapists need to listen to the patient and think creatively about how to make their patients comfortable. Really, really encourage customized immobilization devices. There's customized head cushions, backwalk bags, obviously body fix. And these things are all in part to make sure the patient is comfortable, but also in the same position, fraction to fraction. And also very, very important is to index these immobilization devices. That means that many of these devices have pegs in them that they, kind of connect into the tabletop so that those immobilization devices are positioned exactly in the same spot for each fraction. So where you have devices that can index, definitely very important to use them. And also document the index where it was positioned. For the second step, which is where we load the planning scan for our reference, in the case of SBRT lung, where we've done a 4D CT, that planning scan is the mean or the average IP image set. Very important to review it. Make sure, look through it, make sure you know where we're treating, where the tumor is that we're treating. You should be able to display the ITV, your PTV, any avoidance structures. And by avoidance structures, we mean structures you want to make sure are out of the field so that those are not going to get a high dose of exposure. And this would be including things like nearby critical organs, such as the cord. If the lung tumor is near the spinal cord, you might want to note that. This also comes into play if you start to encounter re-irradiation, where the patient comes back for treatment and you want to avoid a certain area from getting more dose. So ITV, PTV, and the avoidance structures are important, nearby critical organs. I also want to highlight, this is one of those kind of practical things that we learned the hard way, which is that the system at the console has a limit, memory limit related to the number of ROIs you can load, especially when you're doing smaller slice width scans. So if you're acquiring T scans with finer slice width, so 1.5 centimeters, for example, 1.5 millimeters, for example, and you have a lot of regions of interest, and those are all loaded onto the console for your IGRT treatment, it can really bog the system down. It can really take a long time to load. So generally, you want to avoid sending the external contour of the body. You don't need to really send over the actual lung contour. You don't really need to send over the skin for IGRT purposes. So just some practical notes about that. Really want to send the structures that you need and try not to send super large structures, because that can actually cause errors at the machine where they're not able to load the reference set and the structures needed for IGRT session. And when that happens, it can be a bit of a challenge where you have to go into the planning system and sort of resend some files over to the machine, and that can be certainly stressful at the console. Okay. Oh yeah.
I just want to take a quick pause. Does anyone need further explanation for what it means to send structures? This is something that when your therapists are looking at the cone beam CT, they'll be able to see how does the anatomy look compared to certain contours that we already made.
Yes, Ben, what I understand is that we will just deliver the area of interest, let's say, not the whole contouring or the whole reference image that we taken during the simulation. Am I right?
So the whole reference so the entire mean IP data set will be sent over. So that will be there. The structures, though, the contours, you can select, oftentimes you can select in your planning system what contours you want to be exportable to the console. And if you select too many large structures, so you have the external, is really like the entire body. And so if you send that contour of the entire body, in addition to the contour of the entire right lung, in addition to the contour of the entire left lung, and sometimes we also have a total lung contour, all of that together takes up a lot of data. And the control console sometimes hits a limit into the amount of data it can load, and then you might get an error message. And so this is just something that I want to share with you from my own experience, that if you can advise your planners, or if physics is doing the planning yourselves, you really want to not send these structures to the console.
Mm-hmm. Yeah, so don't send these ones. These are huge. We'll slow things down.
Right.
Make sure you do send the ITV and send the PTV. You want to align and make sure the tumor is as much as possible in the ITV, and then definitely has to be within the PTV. And then if there's any like critical organs that are nearby, you can send those. And anything additional that you made that you want to make sure to avoid, meaning you don't want the dose to go there, you can send that as well.
Mm-hmm.
Okay, sorry to slow you down.
No worries. The questions are really helpful. And actually, I see a question about if you have a central lesion, would you recommend sending the heart PRV? Yeah, I think that would be good to do. And then another question about slice thickness. So the slice thickness you get from 4D would be different from what you get in this cone beam. Does it make any difference in matching both images with respect to GTV? So the cone beam CT is right. It's not going to be the same resolution. It's certainly not going to be the same quality as your planning CT. But basically what your goal is at the console is positioning the patient. We're not doing dose calculations on the cone beam CT, at least we're not talking about that here. And so what you need the cone beam CT to be of high enough quality that you can align, that you know how to set up the patient. So generally speaking, it's okay. It's basically like, in short answer to your question, it's fine. You want your planning CT to have the high resolution and quality because you're calculating dose on that, and because you're using that for contouring. The cone beam CT at the machine you're using for setup. And so there is going to be some inherent difference there, and that's okay. Let's see. Okay, so we're going to acquire the cone beam CT images, and then we're going to register. I know it's a lot of bullets, but I think these are really important things. For your specific LINAC, your LINACs come with manuals, and it's really important to understand the cone beam CT protocols that come with your specific machine. And the machine has default settings, and the default settings are by and large fine to use. But it is really important to understand what those different protocols are so that you can advise the therapist on how best to use them. Generally speaking, here we use on our variant true beams, the low dose thorax call, or we use the spotlight protocol. And we found that what's nice about the spotlight, it is a smaller field of view. So here's an example. You don't get the full patient image, and that's okay. We're able to just focus in on where we are targeting. And in terms of image quality, it is enough. It is most of the time good enough for us to set up. Sometimes, particularly when we're doing more soft tissue treatments, so not lung, but pancreas or liver or something like that, we would want to do, we generally would maybe avoid the spotlight. But because the lung, you get really great contrast between the lung tissue and the normal body tissue, spotlight or a low dose thorax protocol is sufficient. But I do want to emphasize that each LINAC comes with its own set of standard protocols, and it's really important to go through and read the manual and talk to the vendor and get training on understanding what those different protocols are. In terms of aligning for registration, generally speaking, we acquire the cone beam CT, the therapist will manually align the image. It's a gross alignment. They'll basically make sure that the two images on the screen are in the right ballpark, and then they'll perform auto matching. If we just do auto matching and the images are disparate, the auto matching algorithm could actually put you in a really different position, and it can be really confusing sometimes on how to align it. So really, really important to first manually align the image grossly and then do the auto matching. Most LINACs have a clip box feature where you then can refine. So let me back up. So we manually align the images. When we do the auto match, we will draw a clip box around the area of interest. That's where it's going to focus on the auto matching. Once it does that, you can then, if you want to go and do a ROI auto matching, sometimes here we do. So what we do at this point is we'll scroll through and check to see if it looks good. Some therapists will manually tweak. Those tend to be the more experienced one, where they know if I shift this way, how it's going to affect in the other three planes. Other therapists who maybe are not as experienced will then use the ROI matching to further refine this alignment in the ROI region. So these are just some tips in terms of how we've approached it here. It's important. You want to center the ITV alignment in all three planes. And by three planes, I mean, this is an axial plane. You're also at the console going to see the sagittal and coronal. It's really easy to just look at the axial, scroll through and think it looks good. Really important to remember to look over at the sagittal and the coronal as well. So, because it's easy to miss something or notice, oh, I'm actually missing this tail end of the piece of ITV here. And so I just want to emphasize, center your ITV in all three planes and really scroll through all three planes. Physician and physicists should review and approve those images at the console before any shifts are applied. This is really important, and I'll come back to this at the end. The therapists are going to be, they're learning how to do this, especially when you're first starting. As a physician, you understand the clinical case. You understand the tumor, you understand how you did your PTV, you know the clinical sort of parameters for this patient's case. The physicist understands the technical aspects. We know how the plan was delivered. We know the arcs that are being used. We know how all of that is going to be affected based on IGRT. Really important to have the physician and the physicist review those images, give the therapist the okay, yes, this looks good, shift the patient, and proceed. This process, especially when starting, can take a long time. And I want to call this out because the therapists will get faster with practice, but as they start, they're really going to want to aim for perfection. They're going to want to really scrutinize, oh, this pixel here, I could, if I can get that a little bit better on this image, oh, but it throws off on the sagittal coronal, so I'm going to tweak that a little bit. And so in the beginning, it is really common to encounter that. And again, this is also why having the physician and the physicist there is really important to say, okay, this is a good match in all three planes. We can go ahead and proceed, because keep in mind, the patient is on the table breathing and waiting to be treated. And so all of this time of manual alignment, clip boxing, reviewing the images, having the physician and physicist look at the image, that's all taking place between the image acquisition and your treatment time. So that time can be a long time. And depending on, and this is also why your immobilization and patient comfort is so important. You don't want your patient to be uncomfortable and like having to move, and then you need to re-image all over again. Okay.
Very good. We do have a question about the reference structures from Abir. We need some reference structures for accurate image fusion if the reference data that we send is small enough. So how we will assure our matching? Abir, do you want to unmute yourself and clarify the question, perhaps?
Good evening. My question is that during the image fusion, we need some nearby structure to assure that we are on the accurate side. So if the data transfer is small enough, so how we assure that our image fusion is proper, is accurate or correct?
Yeah, that's a good question. So sorry, I'm trying to get to the spot. So yeah, you're right. You having help reference structures are going to be helpful. And those are the structures that you do want to send. So whether it's nearby critical organs, whether it's your heart PRV, in terms of checking your image fusion. So I think what you're asking is, let's say your ITV is on, but your other structures are not aligned. Is that kind of maybe what you're asking?
Yes.
Okay.
I'm asking that.
Okay, that's another reason why it's important to have your physicist and physician there. Okay, here, because that's definitely, and that's also why it's important to turn on your critical organs, because it'll make the therapist not just, it's really easy for, I shouldn't say it's easy, but it is not uncommon for the therapist to only look here at the ITV and PTV when they're looking at the registration and not looking anywhere else. So I think your question is actually a very good question. It's a very important point. When reviewing the alignment, you do also need to look at where your other critical organs are. And sometimes that requires a judgment on the clinician's part to decide, you know what, I'm going to actually allow for this tumor to be shifted in such a way that the ITV is not aligned because of this really important avoidance structure that I absolutely need to avoid. So if you, for example, let's say we had a tumor, down here, right near the spinal cord, we absolutely do not want to overdose the spinal cord. That's going to be our main priority. And so, it is a discussion at the consult between the physician, the physicist, and the therapist to review the images and determine, okay, I understand that I'm not aligned perfect. My ITV is not aligned perfectly in the middle, but I'm doing that because I need to keep my cord out of the dose, out of the area of treatment. So there's not a definitive answer that's going to apply for all cases. It's really case specific, and it really depends on sort of the location of the tumor. But we do encounter situations where we will purposefully not align perfectly to the ITV because of these other constraints that exist. Yeah.
Thank you.
Mm-hmm.
And by this fusion, we can also correct the rotation error in such a small snapshot of the verification image. I can from here know what is the error of the rotation and correct.
Yes. So rotations you can correct if you have a couch that can do rotations. So if your couch has 6 degrees of freedom, you can do that. You can also try to manually rotate the patient. That's a bit trickier. You're definitely going to want to re-image the patient if you, kind of try to adjust the role of the patient. A better option if you don't have a 6D couch is you do the match and then you zero out the rotations. So it'll say, okay, you've got like a 0.5 degree roll that you need to apply. You can go in and you can basically set those to 0 so that you're only doing translational rotation, translational positions or shifts. And that's what you want the physician and physicist to review. Because if your system is not able to automatically apply any roll, pitch, or yaw adjustments, you don't want to do that manually.
Good. There's a question from Iqbal Alamri. What is the max couch rotation we can apply for SBRT treatment?
That's a good question. Typically, I would say maybe on the order of 1 degree. Now, rotations are tricky because if you think about where your isocenter is, so you have the patient here, right? And if you roll the patient about a certain axis, if the tumor is close to where those axes intersect, you don't really have to rotate too much. If your tumor is distal from your central axis, a little bit of rotation is going to have a lot of effect, right? You're just talking about like sort of radial geometry here. So I generally wouldn't see rotations, certainly not more than 1 degree. But again, this is another reason why it's important to go and be at the console to see the images. There's definitely, I'm sure there are clinical cases where we've rotated more than that. And basically, I think as a program that's starting up, these thresholds that you're going to want to develop are going to be based on the experience that you have. So definitely you want to be at the console for all of these images. Your record and verify system will collect the rotations that are applied so that you can see for your SBRT patients, as you develop a patient base, where are you seeing most of the rotation, or what is your average couch rotation that you're seeing? And then you can set some guardrails or some limits on that for your therapist moving forward. But at the beginning, I would say you need to look at the images. If it's about 1 degree or less than that, I would definitely take a closer look, but that's not to say that it's wrong. And it does depend on sort of where the tumor is relative to your central axis.
Okay, great, Emily.
Okay, so shifting to patient, I just want to bring up that if you're giving a high dose, it may, especially if you're starting out, I would recommend repeating your cone beam CT after shifting, particularly if your shift is large relative to your margins that you use. If you're giving a very high dose per fraction, for example, 18 gray times 3, and if you've been, if the team has been working on alignment, registration, other things, and the patient might have moved, you definitely want to repeat the cone beam after you've shifted to make sure you're on target. And so this is an additional step here in the IGRT process for SBRT lung, especially as you're starting out in a program. Once you've gotten comfortable with the process and you have a better understanding of all this, then you can then decide, okay, only if I'm shifting more than a certain amount do I then want to do a cone beam, and you can develop guidelines that way. But to start, I would repeat cone beam after shifting, especially if you have a new team and this is something new for your practice. And then delivering treatment. While you're delivering treatment, you definitely want to watch the patient for movement. This is true of any treatments we give, but especially for SBRT where we're giving high doses. If you're doing multiple arcs, multiple VMATs, so you're doing an SBRT treatment and you're doing 1 arc and then you're doing another arc, sometimes maybe 3 or 4 arcs, definitely not a bad idea. I would recommend imaging between arcs. Again, especially if you're doing a large fractional dose. So you're going to do 1 arc, then you're going to image to make sure the patient hasn't moved, and then you deliver your 2nd arc of treatment. So this can be a lot of imaging time. And again, your treatment time is going to be long, but it is important to get comfortable and understand the treatments that you're doing. We do this. We do verification scans after shifting, and especially for giving, if it's like a single dose SBRT, extracranial SBRT, we absolutely will image between arcs to confirm that the patient hasn't moved. Okay, I was going to shift now to spine. I know we're over time. I hope, is that okay? Or sorry.
Yeah.
Okay.
I think as long as it's helpful, I think we still have basically everyone on.
Okay. So Shifting to spine now, immobilization is important. And I'm showing here an example of a spine case with a contour. This green structure is a tumor volume contour. This is where we want to treat. Why is immobilization important here for spine SBRT?
Feel free to type in the chat.
Oh, okay. Sorry.
Spinal cord dose, says
Yes.
Mary.
Exactly. Spinal cord dose. That's right. We're right up against the spinal cord. Exactly. Critical structures. Sometimes in this case, it's really only the spinal cord. Sometimes you might be up against artery, you might be up against the heart, you might be up against some other critical structure. And so really, really, really important to have really good immobilization. And I'll go into a little bit about what I mean by that. So at simulation, because we're going to do spine SBRT, and let's assume we're doing this case here, this is what we want to treat. We're going to use a scan acquisition of 1 to 1.5 millimeters slice width. And the reason is because the structure is so small in terms of your soup to imp. You really want to be able to decipher, since we're going to give a large dose here, and we really want to avoid a critical structure abutting this target volume. We want to have really good resolution. So we're going to do 1 to 1.5 millimeter slice width. For immobilization, must have a backlog bag. Must have a backlog bag. Some kind of custom bag that the patient is going to be is well molded to them, because motion in any sort of way, like wiggle way, is going to potentially be impactful in terms of targeting this without any adverse effect. And yes, we do draw the cord and the canal as OARs. Again, I want to emphasize indexing that immobilization device is really important. And generally speaking, we treat with arms up, because if we're treating the spine, we don't want to have beams go through the arms. So we want to treat with the arms up. Now, what is wrong with this scan? Is this a sufficient simulation scan for a spine SBRT? And I'll give you a few seconds, but I'd like to hear any thoughts. Do you think we only need to scan this length? Is that sufficient for spine SBRT, given that we're only treating this anyway? Right, we need more. Why do we need more?
We cannot know which vertebrae is it.
Exactly. You need to scan long enough to be able to confirm you've got the correct vertebral body for treatment. You need to scan long enough so that you can, at a minimum, count either from the top or the bottom, either from the ribs, or somehow have some really clear anatomical landmarks to identify that you are on the correct vertebral body. And I'm going to come back to this point over and over again, because it comes up from time to time. Oftentimes we're very worried about, when we talk about SBRT for spine, we're always worried about the cord dose and things like dosimetric like that. But this is really, 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 really important. So setting up the patient, we're going to go through the IGRT process now, talking about for spine SBRT. So set up the patient on table using our immobilization devices from SIM. Again, detailed notes and photos are key. Again, these treatments tend to take longer. Make sure the patient is comfortable. Customized immobilization devices are important. If you're doing treatments in the upper spine, head and shoulder mask is helpful for making sure that they're not moving, that there's no twist up top. Customized head cushions to make sure their head pitch is in the same spot. Certainly custom backlog bags or a body fix system. And again, indexing is very important. In terms of imaging, so I highly recommend starting with a KV ortho pair first. Confirm that you're on the correct vertebral body with your DRR as your reference and an open port film, so that you're where you need to be, and do your initial gross shifts based on that. That way, you're in the right area. And then when you do your cone beam, because your cone beam is going to be, a smaller field of view, it's not going to give you this nice big picture. So your cone beam will be targeted on the right area. So really important. First, take a KV ortho pair, confirm you're on the right vertebral body with your DRR and your port image, and then do your shifts. Okay. Then acquire your cone beam. Then turn on your GTV, your PTV, your cord, any other avoidance structures that are in that area. And then note that, again, especially because we're scanning with such small slice widths, 1 to 1.5 millimeter slices, you do not want to send over your external contour. It'll really, really, really bog down the system. So again, just a note of practicality there in terms of kind of doing these at the machine. Okay, now we're going to register a cone beam. Sorry, my animation's a little bit off. Your cone beam CT should already be close due to the port films that you took. That being said, you do want to check. So look for landmarks. You're going to first do auto match by clip box on your GTV and CTV. Check your cord alignment, review alignment in all 3 planes. Once again, you want to look not just on your axial slices, not just here. You want to look at it in your coronal and your sagittal views. And I want to talk about toggling. I wish I was able to capture like a screencast of this at the machine. At the machine, oftentimes you can see your cone beam CT and your reference CT overlaid on each other, either grayscale on grayscale, or sometimes you can see different colors, blue on orange, and you scroll through like that. I really strongly recommend. That's great for just initially making sure you're, kind of in the right ballpark if you're trying to like align something like this. But then it's really important to actually toggle. And what I mean is flip back and forth quickly between your cone beam and your reference CT, like go back and forth, like just like this. It doesn't make that sound, but go back and forth between the images so that they flash. You have your cone beam, then your reference, and your cone beam, then your reference. And that way your eyeball is going to be able to tell you, you'll be able to very easily tell how close you are, how well aligned you are between the two. You'll also be able to see around not just around where the spine is or where your target volume is, but the other organs. Is there a twist? Is there a roll? Is there something else? It'll really inform how you can better align. So I wanted to really make sure to call that out, that it's important to not just do the overlay, scroll through and say that looks good, really actually toggle and do that quick shifting between CBCT and your reference image, because that's going to give you a really good way of determining whether you're on target.
Can you explain what a clip box is again? I think that's a new term for some.
Oh yeah. So the clip box, when you contour when you acquire your CT scan, oftentimes it's an axial view. When you do auto matching, one of the ways you can do auto matching is you define what's called a clip box. And it's basically a rectangle that you would draw around your region of interest, plus maybe some, in this case, ribs and some bony anatomy. Exactly. And then you would say, okay, auto match here. And what it is the auto matching algorithm will focus in on this area to find better alignment between your cone beam image and your reference. So this red rectangle there that bend really nicely is called the clip box.
This is regarding any machine, Varian, Electa, any, or this is specified for Varian?
I'm trying to remember the Versa. I think it's both machines refer to it as the clip box, but I can double check on that. Yeah.
Okay.
Yeah.
Okay. Thank you.
Let's see. Okay. Again, reiterating, physician and physicist should be present to review and approve the images at the console. If the alignment looks off, pause and retrack the gross level and position. I cannot, it's really, really important. If it looks off, listen to that, take a closer look at it, point it out to the clinician and the physicist. This doesn't look right. This scan, there's this little notch here, but then on this scan, the notch is not there. And just take a moment to really scrutinize that. And again, check for roll, pitch, and yaw, and that you'll see when you toggle. And if you have a couch that can correct for that, great. If you don't, you'll need to zero that out. So because you can only make translational shifts. And so you're going to need to find the best alignment based on that. Okay. So now we align the patient and we're going to shift the patient. Again, it'd be good when starting to repeat your cone beam CT after shifting, especially if your shift is large relative to the margins, if you have very high dose per fraction, or if you think the patient might have moved, and then deliver your treatment. So you want to really watch your patient for any movements. And again, if there's multiple arcs, image between arcs, especially if it's a large fraction dose or a long treatment time. Okay, Some comments on physician and physics presence for SBRT treatments. When starting an SBRT program, it is really important for physics and the physician to be present at the console. This will reduce delays. You know how I mentioned that sometimes between imaging and determining your shifts, that can take a while because you're really trying to find perfect alignment, and it's really easy to just lose track of time, honestly, trying to do that. So having the physics and physician there at the console will actually reduce delays. The AAPM and the ACR Astro guidelines strongly recommend that physics is present and supervises the SBRT treatments from initial patient setup through treatment. So especially when you're starting, essentially what we would do is you'd have the therapist say, call the physicist to the console as soon as when the patient is entering the room, so that physics is able to be there and to supervise and be present for the setup of the patient, the imaging of the patient through registration and all that. I've experienced times where sometimes I get called to the machine after they've already done their registration and they've already, everything's all set up well. And so I'm looking and I'm toggling the images, but I've missed out on the challenges that the therapists have encountered in terms of, this patient has been difficult in this way, or, we had to image, 3 or 4 times to get a good alignment. Those kinds of that kind of information is really important to be present for and to know about. And so while we certainly encourage the therapist to always call physics whenever there's any sort of or anything like that, sometimes the therapists are busy. Oftentimes they're just trying to get through. They think they can, they're very capable of problem solving it. And so sometimes they'll just work through it. And you don't, as physics or physicians, we don't hear about these things until maybe after the fact. And it would have been important to know about it early. So especially when starting out SBRT, and certainly as the program evolves, it's really important to have physics present from the initial patient setup through treatment. Also, the physician should really review and approve those images before every fraction. This is SBRT. We're giving high doses at each fraction. And so before each fraction, really want at minimum, a physician to review those image alignments, ideally physician and physics when starting out. And I just want to emphasize again, there's no substitute for directly observing the challenges, whether it's the therapist's setup, immobilization, imaging, registration challenges, all of that. Being there really, really helps a lot. It can be time consuming and require a lot of coordination, but I really want to encourage that SBRT practices have physics there, especially when starting out from the beginning through the end of that treatment. And
how much shift can be applied without needing to repeat a cone beam CT? This is a question from Ed.
That's a good question. Generally speaking, if it's less than a millimeter in any direction, then we don't repeat a cone beam CT. That being said, when we were starting out, I wasn't here at UCSF, but at my previous place, no matter what the shift was, we repeat cone beam at the beginning. So even if the shift was very small, we re-cone beamed, because for us, it was important to understand what the baseline is, what we can expect as a baseline for these shifts.
Good question.
And then be aware of any unexpected differences, think systematically, and be resourceful. What that means is, sometimes you're at the console and something's not looking right. Something's not quite getting right. Take a step back, think systematically. Okay, it's either like you have the simulation reference, or do I have the right reference loaded? Are we missing anything on the setup? If you're doing spine, are we at the right level? If you're doing lung, is the patient breathing differently for some reason, such that the image is not, the tumor is not falling well within the ITV? And be resourceful, meaning you should be able to access the plan so that you can look at the plan and reference that. You can look at the CT scan and reference that. Certainly, call the physician and have a discussion. If you have other physicists around who can partner with you, call the physicist. So just be aware this happens and it's okay. Be resourceful, take a pause. And just be sort of systematic about trying to troubleshoot what it is that you're encountering. I just want to make sure it's, it's not uncommon, especially when starting out, that these things happen. And so it's okay. It's okay that these unexpected differences pop up. Okay, now we talked about verifying vertebral body. This is a screenshot from a report. So Astro has a radiation oncology incident learning system called Rayos, and they have publish these reports quarterly. And I highly recommend that take a time to read these reports, because basically it's a description of radiation incidences that have happened to any sites that participate in this Rayos program. And they do a really nice job of describing the issue or the incident that happened, and then kind of some bulleted, very targeted points about things that can be done to address. So this was a case in 2015 Q3 report where basically the incorrect vertebral body was treated. And, the automatic image alignment algorithm locked onto the incorrect vertebral body. And this, in this case, resulted in a large shift of the patient. The incident was discovered on the third fraction when the treating therapist noticed a discrepancy. So again, cone beam CT is great. Auto matching is great, but you have to be aware of this limitation. And so recommendations: over-reliance on modern technologies like cone beam can present problems when we have tunnel vision and are only focusing on that cone beam in that region of interest. So they recommend having a policy procedure. So, setting some guidelines. Hey, a vertebral body is about 1.5, maybe 2 centimeters dimensionally in the soup to M. So if you have to shift 3 centimeters, that's definitely more than one vertebral body potentially away. And so that's the reason for this guideline. Another was to, try to use a cone beam setting that captures a larger extent. I think that even if you're like middle of your T-spine, even if you use the larger cone beam CT, you may not necessarily be able to see enough to count correctly. So definitely this orthogonal planar images to verify alignment, I think, as a first step to get you to the right vertebral body is a really important thing to do. Highly recommend. And I have a reference to that at the end. Okay, so in conclusion, understand how to use 4D CT. I hope I helped explain, sorry. I hope I helped explain more clearly how 4D CT works, what the maximum intensity projection and the mean intensity projection images are, and how they can be used for lung SBRT. Another point is certainly make sure you have enough imaging information, whether it's your scan length, landmark, to confirm that you have the correct vertebral body for spine SBRT. Reacquire your cone beam between arcs if you have a high dose per fraction, patient moved, long treatment. I should add in between shifts, because that's another point. And again, physics and physician presence at the console is key to kick off safe SBRT practice. So I think those are kind of the main sort of takeaways from this session that I wanted to provide. I hope I left you with some kind of practical tips from things that we've learned from our own experience. And then I believe coming up next will be lung SBRT case-based learning in the next future session. All right, yeah. Here are the references. TG 101 from the American Association of Physicists in Medicine. This is a really great report on stereotactic body radiation therapy in general, including dose constraints and limits. This is a great report on respiratory motion. It goes into a lot of detail about 4D CT. And so I definitely want to point you to that document. This is about sort of the practice of SBRT in a clinic in terms of your physician, your physics, your therapist, dosimetrist training, and what that program should look like in the operation. So beyond just the technical hands on the machine, but policies and procedures, guidelines, and things like that. So wanted to point you to that. And then again, the incident learning reports are just like awesome to read. We learn from our own mistakes. We should learn from everyone else's mistakes collectively. I think that's an even better way for us to get better at what we do, so that we certainly don't have to make the mistakes to learn from each other. So I just want to really point that out. And then a couple of additional papers as well.